All right, so we're going to talk about blood gases, and this is one of the best methods I've ever learned ever. A friend of mine helped me write this lecture a couple years ago. A very smart gentleman named of Dave Ellis. He's a flight paramedic, highly skilled in critical care and flight medicine, very experienced as far as respiratory and critical care patients go. And so I thank Dave for writing this for me a couple years ago. And he's allowed me to continue to share it in classes. He's very excited that people get so much out of it and enjoy it. And I think you'll find it works for you as well too. All right, so let's talk about some blood gases here. So the first few minutes is just kind of a review of some basic concepts, stuff you probably already have a basic understanding of, and then we'll go into the actual method of how to interpret these and make them useful. So we are going to be talking about the pH, the PaCO2, the PaO2, the O2 sat, and the base excess or deficit, which is also basically the bicarb. So it's a real simple, easy learning curve as far as that goes. Now, your body wants to keep the pH in a certain range. That's where things work best. And the pH basically reflects how many free hydrogen ions you have. So it is an inverse relationship. In other words, the more hydrogen floating around, the more hydrogen ions, the lower your pH is. So when you're acidotic, you have more free hydrogen ions. And then when you're alkalotic, it's just the opposite. But we're going to take that whole inverse and opposite out of it and make things a lot easier and less likely to get things the wrong way and have a problem when you look at these blood gas problems. The normal value of our pH is 735 to 745. And that's really all your body cares about. Your body doesn't really care about the PaO2 or the CO2 or the bicarb. Your body, what it really looks at first and foremost is the pH and says, am I where I need to be, where things work well and normal metabolic and physiological processes go on efficiently? And if it's outside that range, it's going to do everything it can to get it back in that normal range there. Some things that don't work as well when you're either end of the spectrum. So if you're acidotic with your pH below 735, some things that don't work very well in that zone. One is you've got less cardiac output, okay? So this is not a good thing because a lot of times when we're trying to resuscitate someone or they're having some of these critical issues going on, they're somewhat acidotic. Whether it be from lactic acid or an anaerobic metabolism or whatever, but this is why you actually need more cardiac output during those times. But if your pH is falling, it's even harder to get that. Your vascular system responds a lot less effectively to the circulating catecholamines, things like your epi and your norepi that are circulating your body and that are released during your sympathetic response. And the blood vessels don't respond as well when you're acidotic. So there again, you've got another problem that if you're acidotic, things aren't going to go well for you. And then some medicines. Medicines were designed and developed to work in a certain pH range. And if we get acidotic, that alters their metabolism of the medications and the effects they're going to have. Now, when we're alkalotic on the other side of the spectrum, above 7.45, this has more to do with the actual tissue, getting the oxygen to the tissues. Also, there's more of an issue with the neuro and muscular control also. This is why when someone is like hyperventilating, which is a respiratory alkalosis, and we'll get there in a few minutes, that's why they might have like the cramping or the tingling in their hands, their feet, their face. That's the effect of the alkalosis on their neuromuscular control system. And so we see problems on that side. So if we start looking at these values and looking at the components of the blood gases, excuse me, let's look at the CO2 first. Its number is 35 to 45. This is something that most of us already know. It's kind of easy to remember that because the pH is normally 735 to 745 also. So it helps with that. Now this is a pressure measurement, okay? It's a pressure. This is how much pressure is keeping the CO2 dissolved in the bloodstream. You don't want CO2 floating around in bubbles in your bloodstream. It's useless and risk for embolism, air embolisms. So this is a pressure, kind of like if you have a can or a bottle of Coke or Pepsi, when you get it off the shelf from the store, you don't see the bubbles in it. As soon as you take the cap off, you're releasing the pressure and those bubbles start to come out of the solution there. So this is a very similar principle here. All right. If we were to stop just here and look at only the CO2 and trying to figure out what disorder I'm having, this slide is just showing that it's not really useful to do that because your CO2 can be altered from a primary problem where it's actually the issue that's going on like a respiratory acidosis or alkalosis, or the CO2 could be abnormal because you're compensating for something. So this is the take home here is just saying, hey, we need to look at more than just one value. We need to look at all these components and then connect some dots and tie the pieces together. The bicarb reflects your metabolic side. Its number is 22 to 26. Not a hard number to remember, but it is a little weird. I mean, our brain likes things that are like multiples of 5 and 10, but it's 22 to 26. And this reflects how much bicarb is floating around the system. Now, this is a measurement number. This is a quantity. So CO2 is a pressure number. Bicarb is, or base excess deficit, is a quantity. And base excess deficit basically means the same thing as the bicarb, okay? It's either how much or how little you have, and it's going to be interchangeable. The same direction the bicarb goes, the same direction the base excess or deficit goes as well too. And if one of these numbers is too high or too low, the other one will be too high or too low also. Okay. This formula on the top of the slide here, this is what is one of the wonderful things about our body, our human organism, that helps us stay in balance in a time of dynamic changes. This formula you can flow back and forth either to the left or to the right, depending what your body needs more of or less of. And the chemical in the middle, the H2CO3, is carbonic acid. Carbonic acid has a unique property that it requires very little energy to combine or to disassociate. And it can go either way, to the left or to the right. So this is basically our buffer system. It's how we stay in a state of constant flux and dynamic change. Looking at the two systems we're going to be talking about, the metabolic and the respiratory system. The respiratory system means the lungs, of course, and that means the CO2, because that's where the CO2 is either given off or retained, is through the lungs. Now, the response of the respiratory system, the lungs, to adjust that CO2 can happen very quickly. All you have to do is either speed up or slow down your breathing. Very fast, the CO2 starts to change right away. That's one of the reasons, or clinical examples, when we talk neuro emergencies and we're talking about head injuries and the risk for herniation, we might hyperventilate our head injured patients because we can change that CO2 very quickly and maybe protect that brain from herniating. The drawback to the lung system or the respiratory system is that it is crude. It's hard to get an exact, precise CO2 and maintain it. Okay, so it can change quickly, but it's not perfect. And then the third aspect to this is that it's not long-term. You can't hyperventilate for hours and hours and hours without something going bad, especially things like respiratory fatigue or respiratory arrest, because eventually your accessory muscles are going to wear out and get tired. So the lungs, the respiratory system, rapid, crude, and more for short term. The kidneys, which are the metabolic side of the body, this has to do with the bicarb or the base excess and deficit. And they're the complete opposite of the lungs. Whereas the lungs were very rapid, the kidneys and the ability to adjust the bicarb is slower. However, it is more precise. It can maintain more of a specific number for a longer term than the lungs can with the CO2. And it's also more sustainable or long term. All right, so the two systems are basically opposite. One is fast, one is slower. One is imprecise, one is very precise. One is short term, one is longer term. So it's kind of neat how our body has that balance to it, that we have like check and balances and compensation, one side versus the other. This picture is just showing the same thing with the buffer system again, just how depending on what the body needs, it can flow from one side to the other to help either increase the amount of CO2 or decrease the CO2, or it can flow the other way and increase the amount of bicarb or decrease the amount of bicarb. And this is where we're going to take the first step to make this blood gas method that I teach friendly and make it more reliable. I've never been a big fan of the arrows or the opposite method or the same, whatever you want to call it. So how do we get rid of that? Because the thing is, if you use like the arrows or the opposite method, then if you get one wrong, then you're wrong from that point forward. So this is the magic to this. Every time we talk about these numbers, and as we go through these practice ones, we're going to remember or say CO2 is an acid. Okay, CO2 has acidic properties, and bicarb is a base. And all I'm going to ask is, do I have too much acid or not enough acid? Do I have too much base or not enough base? And as a result of that, what is the effect it's having on the body? For example, if I have too much CO2, I have too much acid, that's going to affect more of an acidotic type effect on the pH. Okay, so that's how we're going to make this stuff work. Now, the first step when we go through these problems is to identify which disorder we're dealing with. We've got 4 main disorders. And let's look at each one of them and see clinically and characteristically what defines them. So the first one we'll talk about is respiratory acidosis. And it's an acidosis because the pH always defines what state you're in. So in this case, the pH is less than 735. And the reason the pH is low, under 35, is because there's a surplus of CO2. Remember, CO2 is an acid. So in this case, above 45, the CO2 is having an acid effect on the pH and driving it towards acidosis. Okay. The universal answer for any respiratory acidosis is anything that causes you to hypoventilate or slow your breathing or stop your breathing. So these are some examples: oversedation, pneumothorax. It could be as quick as a airway obstruction. Someone's choking on a piece of meat at the dinner table. They stop breathing. The airway is obstructed. That's a respiratory acidosis. These are all things that slow, stop, or obstruct or impair the breathing process. The other side of the spectrum, if we're in a respiratory alkalosis, it's an alkaline state because it's above 7.45. The pH always determines what condition, what acid or base state we're in. And in this case, we see that the CO2 is less than 35. CO2 is an acid. I've lost some of my acid. When you take away some acid, it's going to affect more of an alkalotic effect on the body. It's just a seesaw. It's just a teeter-totter. You take something off one side, the teeter-totter goes the other way. So I've lost some of my CO2 acid, makes me more alkalotic, and that's what's driving the pH above 745. And this is the total opposite of respiratory acidosis. This is anything that doesn't make you hypoventilate, but makes you hyperventilate. Stress, pain, fear, anxiety, stimulants, right? Those kind of things. The metabolic acidosis, it's an acidotic condition because the pH is less than 735. But in this case, it's not a CO2 problem. It's a bicarb problem. The bicarb is abnormal and it's less than it should be. It's less than at 22. Bicarb is a base. If you are deficient or take away or lose some of your base, that's going to exert more of an acid effect on the pH. Okay, so it's the lack of bicarb that is pushing the pH towards the acid side. Now, the examples of this, the nice thing about this clinically is a lot of these have the word acidosis in them, or you can connect the dots. For example, we have DKA, diabetic ketoacidosis. When we have sepsis, we have lactic acid. When you're starvation, you've got ketones build up from fatty acid breakdown. Okay, that's an acidosis. Salicylates, that's your aspirin. So an aspirin overdose. What is the shorthand for aspirin? It's ASA, acetylsalicylic acid. Aspirin overdose causes an acidosis. So you can kind of connect some of these dots as you're trying to put a clinical picture to this metabolic acidosis condition. And then the last of our major 4 disorders is metabolic alkalosis. It's alkaline because the pH is above 745. And in this case, this is the surplus of bicarb. The bicarb is too high. Bicarb is a base. You've got too much of it. It is pushing that pH towards the alkaline side of things. Okay. Now, this one is actually kind of hard to occur. It doesn't happen that often. In just personal experience clinically over the years I've done emergency medicine, we don't see this one as much as the other ones. So you can have a metabolic alkalosis from too much base. Okay, so that could be like a Tums overdose. Now, that's not really something practical. You'd have to eat so much Tums that it'd probably be hard to actually happen. But it is scientifically and physiologically possible. Too much base in your body, metabolic alkalosis. This one has a second one that can happen that we do see clinically. All right. You can get this metabolic alkalosis from a loss of acid. Remember, it's a teeter-totter. It's a seesaw. If you lose some acid, it exerts more of an alkaline effect. Now, the acid we're talking about here is not the respiratory acid of CO2. We're talking about metabolic acid from the main part, which is hydrochloric acid from the upper GI tract. So 2 of the more common examples are if the person's having profound vomiting, just all this retching, and they're losing out hydrochloric acid, that's a deficit of the hydrochloric. So that's exerting more of an acid effect. Or maybe someone's like unconscious or a trauma patient we have that NG tube in, and oops, we left it on high, full suction for like several hours, and we're sucking out all that hydrochloric acid. Okay, so not as common here with this one, but we've got two different ways we can get to it. And we'll look at it as far as looking at the actual numbers and some clinical scenarios here. So after we decide which of the 4 main disorders we're dealing with, the next step is to start to look at compensation, okay? So if one system is the problem, and when I say system, I mean like if it's a respiratory alkalosis or acidosis, then the other system, the metabolic side, has to compensate. It's just a law. It's just a rule of science. If it's a metabolic problem, then the respiratory has to compensate. So when I say the compensating parameter or the compensating system, what I mean is the system that's not the problem, okay? So when we're in an uncompensated state, let's say we're in a metabolic acidosis, the compensating parameter would be the respiratory, and respiratory means I'm looking at the CO2. If I'm uncompensated, that CO2 will still be normal, okay? As I start to compensate, the one system that's going to compensate and basically save my body, it starts to be out of range, but it's not out of range enough to make the pH normal. And then fully compensated is when the compensating system, that value is out of range, and it's out of range enough now that it's driven the pH back between 735 and 45. So it's just a stepwise progression. And if you look here at this table, which is in the handout also, you just see that progression. So you see here, one system is the problem. Let's say it's a respiratory problem. The CO2 will always be abnormal. It'll always be out of that range of 35 to 45, okay? The other system, the one that's going to compensate, the one that's still functioning, okay? In this case, this would be the metabolic system, which means the bicarb. When I'm uncompensated, the bicarb's normal. It's between 22 and 26. When I'm partially compensated, that bicarb shifts out of range, but not enough to put the pH normal yet. And then the last progression is the bicarb is abnormal enough that the pH is back in its range there. So you just see as a linear progression, you got one system that's always the problem. The other system starts to change and then eventually changes enough that it drives the pH back in normal range there. So just to tie it all together, and then we'll go through a couple examples here. So what we're going to do is we're going to look at each value, each of the numbers, each of the components individually and give them a name. We're not going to worry about which way it's going. All we're going to do is we're going to look at the pH and say if my pH is above 745, I'm going to label that pH value alkaline or alkalosis. If my pH is less than 735, I'm going to name that value acid or acidotic. Same thing with the CO2. And here again, I've put this on two separate slides so it doesn't confuse us as far as opposite directions or whatever. All I'm going to do in step 2 is look at my CO2 number and decide, is that CO2 number an acid number or an alkaline number, and give it a name. And then here's where the bicarb and the base excess deficit are the same thing. They mean the same thing. All right, if I have a base excess above +2, that's the same as saying my bicarb is above 26, and that would be reflecting an alkaline value for that parameter by itself. If my bicarb is less than 22, that means my base deficit is also less than -2, and that's exerting an acid effect. Remember, it's just a teeter-totter. If you're deficit on one side or you have less on one side, the teeter-totter goes up on the other. So if I've lost some of my base, if I'm less than 22, that is going to be an acidotic value. Now, these are just the steps that you have on your handout. We're going to go through these steps. This is where the method starts. So we've just kind of laid the groundwork. Now we're going to tie it together and actually go through these steps, doing what we just talked about. Okay, this is just for your reference. So after the presentation or on your own study, you've actually got them written down for you. But we'll go through these exact same steps with the instructions. And it's about building a pattern. It's about building a habit that you can do every time you want to look at a blood gas, about building memory, about building repetition. So I encourage you, if you want to practice this on your own, to do it the same every time, follow all the steps. Even if you think you know the answer and you're only halfway through the steps, still do all the steps to build that pattern and that repetition. Okay. So on the back of the handouts, We're going to do 6 of these together. The first 2 you have filled in, and we'll go through those steps that were on the previous slide. So looking at problem number 1, again, we're going to look at each number individually and give each number a name, okay? So with a pH of 7.3, I need to decide, is that too high or too low? Is it more acid or alkaline? And of course, at 7.3, that is an acidotic value. So right next to that number, I write the word acidosis or acidotic or acid, whatever works for you. I move to the next number, and I always do them in the same order also. So I look at the CO2 for step number 2, and I say, is a CO2 of 50, is that too much or not enough? Okay, normal range is 35 to 45. So in this case, a CO2 value of 50 is too much, and CO2 is an acid. So I can label this value of 50 as being an acidotic value or acidosis. Then I look at my bicarb next. Normal range is 22 to 26. So this is in the normal range. So I give that the name normal. Now, when Dave wrote this lecture, he put in some oxygen values as well too, because sometimes that helps gives us a little more of a clinical picture of the patient. An arterial oxygen of 80, as denoted by the PA, all right, the letter A means arterial, 80 to 100 is normal for that. So this is good. So this guy's okay. Now, if that was a pulse ox, where it was like SpO2 or SvO2, meaning venous, 80 would be bad, but this is arterial, so this is okay. So the next step, we have to identify the problem. All right, we've given all our names out. So we go to the pH, and I see that the pH is an acid value. And then I look at my respiratory, my CO2, or my bicarb, the metabolic, and decide which of those values matches the pH. In this case, the CO2 is an acid value also. So the CO2 matches the pH, so that means this is a respiratory acidosis. The CO2 is the problem. The respiratory system is the problem. So it's a respiratory acidosis. And now I want to think clinically and remind myself, what kind of patient could I be having here with this? So causes of respiratory acidosis, the universal answer was anything that makes you hypoventilate or impairs your breathing. So this person's having a breathing problem. Is it trying to correct itself? We've decided it's a respiratory problem, and by rule, the other system has to compensate. So that means I go and look at the bicarb now, or the metabolic, and I say, is 24 normal or abnormal? 24 is normal, so it's not doing any compensation yet. Remember, the other system has to start to change to compensate. In this case, it's not changing. It's still between 22 and 26. And of course, the last question is, has it compensated? Well, we already know the answer to that, but we want to build our pattern. So we go back to the pH and say, is the pH normal or not? The pH is abnormal, so it's not a compensated state. So now we know everything we need to know to have the full answer for this. So this is an uncompensated respiratory acidosis. It's a respiratory problem. That's what I need to address as a clinician, as the nurse, or the provider. I need to fix their breathing. If I don't fix their breathing, they're going to start shifting their bicarb to compensate. And that's going to start causing some other problems. Okay, so uncompensated respiratory acidosis. Looking at number 2. So I look at the first value, the pH is 7.3, and I give that a name. It's too low, that's on the acid side, so 7.3 is an acidosis value. I look at the CO2 next. Normal range, 35 to 45. So 36 is normal, so I can put normal over here. And then I look at my bicarb. Normal range for bicarb is 22 to 26. This value of 14 is too low. Bicarb is a base. I have less base than I should, so that's exerting an acid effect on the body. A bicarb of 14 exerts an acid effect on that pH. So I give it the name acid. And I'm a little hypoxic at 70 here. I told you the arterial was normally 80 to 100. So maybe there's an oxygen problem going on here too. But let's not jump to conclusions yet. Let's do the process. So step 1, name the disorder. So the pH is acid. The bicarb is also acid. All I'm doing is matching those two names up. And bicarb means metabolic. So this is a metabolic acidosis. Examples of this is the one with the DKA, the sepsis, the salicylates. So we got kind of a little picture here of what could be going on with my patient. Sounds like more of a medical kind of patient versus a respiratory one. Is it trying to correct or is it trying to compensate? So we've decided it's a metabolic problem, which means the respiratory side has to compensate, which means I go and look at the CO2 and I say, is the CO2 of 36 normal or abnormal? Well, we decided it was normal. So it's not doing any compensation yet. The CO2 is not changing yet to try and offset this. And then the final question, has it compensated or has it corrected? Go back to the pH. Is that pH normal? No, it's still abnormal. So it's not compensated. So I now have everything to give the full name for this, which is an uncompensated metabolic acidosis. So if I let this person continue to be sick, eventually the body will start to adjust the CO2 to try and offset that. My job is not to mess with the CO2 if it becomes abnormal, but to fix their metabolic problems. So if they're a DKA patient, give them some insulin, give them some fluids. If it's a septic patient, we got our whole sepsis bundle. Treat the underlying problem. All right, the next ones, you're going to write in the values yourself as we do them. And as you write each number, go ahead and name it and be done with it. So the first number is 7.47 for the pH. Let's go ahead and name that. Above 7.45, we're dealing with an alkalosis. So I label that alkaline. I'm going to write down that CO2 of 30 and remind myself that CO2 is normally 35 to 45. So this is too low. I don't have enough CO2, and CO2 is an acid. So on my seesaw, my teeter-totter, if I'm low on the acid, it's exerting an alkaline effect. So a CO2 of 30 is an alkalotic value, or alkaline or alkalosis. Bicarb of 18. Normal range here is 22 to 26. So I don't have enough bicarb. And if you take away some bicarb, which is a base, you have less base than you should. That bicarb of 18 is exerting an acid effect on the body. So it gets the name acid. And we're okay with an oxygen of 81. So to name this disorder, we look at the pH. We note that the pH is an alkaline value. And which system is also labeled alkaline or alkalosis? Well, that's the CO2. We've labeled that value of 30 as an alkalotic value, and CO2 means the lungs. So this is a respiratory alkalosis. Okay, the underlying problem here is respiratory alkalosis. And that's anything that does the opposite of respiratory acidosis. Respiratory acidosis means you weren't breathing enough. Respiratory alkalosis was the opposite. It was hyperventilating, stress, pain, fear, anxiety. Okay, so a hyperventilation of some kind. Is it trying to correct itself? So we decide it's a respiratory problem. So we look at the other system. We look at the metabolic side, which is the bicarb value, and say, is bicarb of 18, is that normal or not? And indeed, it is abnormal. So there is some compensation happening here because it's out of its normal range. But has it fully compensated? Is it changed enough to make the pH normal? And the answer is no. So the full name for this one is a partially compensated respiratory alkalosis. Okay, so the CO2 matched the pH, so it's a respiratory alkalosis. The bicarb of 18 is abnormal, but not enough to make the pH back in its range. So partially compensated respiratory alkalosis. So this person has been hyperventilating enough that the bicarb's starting to change, okay? So what do I treat in this patient? I don't treat the abnormal bicarb. I treat their respiratory problem. I get them to slow their breathing down, and if I can fix that, then that bicarb will go back to normal. Okay? That's why it's important to know what state we're in, because if you don't know what state you're in, you don't know what to treat. Or the first thing, and one of the rules of this business is you always treat the underlying problem first. You know, if you only have one choice of, you get one choice of one intervention, what do you do first? You treat the primary problems. In this case, I needed this person somehow to slow their breathing down. I don't go in there and give them bicarb. Okay, that's one of the neat things that identifying what disorder they're in, you know what to treat. And if you're doing this for any exam study, like most of the class is doing for CEN exam, when we do this, I talk to the students about that's how it's useful for an exam, because when they ask you to pick an intervention, you know, for example, this one, you have to pick a respiratory intervention, something to do with their breathing rate. You don't pick giving them a medicine or fluids. you pick something that's a respiratory intervention. All right, number 4, a pH of 7.52. So again, our range is normally 35 to 45. In this case, it's too high. So this is an alkalotic value. And then my CO2 of 50, normally 35 to 45. In this case, it's too high. I have too much CO2 on board. CO2 is an acid. So what would a value of 50 affect? It would affect an acid type push. And then base excess of +3. Normally, base excess / deficit is -2 to +2. So this is too high. Base excess means the same thing as bicarb. So this would be the same thing as saying my bicarb is above 26. And when my bicarb is above 26, that's an alkalotic value because bicarb is a base and you have too much of it. And the oxygen is doing okay here. So to name this one, I note that my pH is alkalotic. And then I also see that my base excess, which means my metabolic system, is also alkalotic. So the underlying problem here is a metabolic alkalosis. And this was the weird one. This is the one that you could possibly, if you took too much Tums, too much base coming in you, or it had the other side, which could be some metabolic acid coming out. Remember, it's just a seesaw. And that metabolic acid was the hydrochloric acid, like frequent vomiting or leaving the NG tube on high continuous suction. So it's a metabolic alkalosis. Is it trying to compensate or is it trying to correct? So I have to look at the respiratory, which means the CO2 number, and I ask, is 50 normal or abnormal? 50 is abnormal. So there is some compensation happening here. Has it compensated enough? So I go back to the pH. pH is still out of range. So this is not fully compensated. This is a partially compensated metabolic alkalosis. So just to put a clinical picture here, this, I said in theory you could overdose on Tums. This person, you know, at least according to the rules of human physiology, if they were to overdose on Tums and really drive up their bicarb, their base excess, how is the body compensating? It's trying to compensate for this. The primary problem is a metabolic problem by compensating with the lungs. And what is it doing? It's trying to offset this alkaline effect by slowing the breathing down. That's how it's letting the CO2 build up. So in theory, you could take so much bicarb or Tums to slow your breathing down because the breathing is a compensation. So in this patient, if this patient presented, my job is not to tell them to speed up their breathing. My job is to fix their metabolic alkalosis. Okay. Now, if it were to get really critically ill and really be a patient in crisis, I would fix it. Of course, they'd be intubated, but I have to make sure that the ventilator setting is correct because I need to get rid of some of that surplus CO2. All right, so partially compensated. Okay, so now we got 2 more to do. So I've got a pH of 7.38. Well, that's within the normal range of 35 to 45. Anytime your pH is in normal range, you need to decide what side of normal it's on. It's like it's leaning one way or the other, even though it's in normal range. So in this case, a 738 is leaning towards the acid side. Okay, it's less than 7.4, which would be the middle of the road. All right, so it gets 2 names when it's normal. And there's a reason for that. CO2 is 27. That's less than it should be. Normally, it should be 35 to 45. CO2 is an acid. And when you lose acid, it exerts more of an alkaline effect on the body. So this CO2 value of 27 is an alkalotic value. Bicarb of 17. Well, that's also abnormal because it's less than the 22. Bicarb is a base. So when I have less base than I should, that number of 17 is exerting an acid effect on the body. Again, just go back to that seesaw, that teeter-totter. If you lose a certain amount of something, it exerts more of the other effect. And our oxygen of 80 is okay. So to name this, even though the pH is normal, I gave it the second name of acidotic or acidosis. So now that gives me something to work with. I can now match this acidosis name to the bicarb, which is also named acid. And now I know that my underlying problem is actually a metabolic acidosis. So the metabolic side is driving this. And those are the things like the DKA, the sepsis, the salicylate overdose, the starvation with all the ketones building up, the ketosis. Is it trying to correct itself? So I've identified a metabolic problem. I look at the respiratory, meaning I look at the CO2 and say, is CO2 of 27 normal or abnormal? And 27 indeed is an abnormal value. So there is some compensation happening. And now the last question is a little different. Has it corrected itself? Well, yes, the pH is between 35 and 45. So for number 5 here, our full answer is a compensated metabolic acidosis. So one of our examples, this patient was like our DKA patient, okay? That's a metabolic acidosis. So if this person was acidotic from DKA, all right, their bicarb is being driven down, that's the acidosis. What's the body doing to compensate? The body is adjusting the other side, the respiratory system. How is it getting that CO2 down? It's speeding up their breathing. This is why your DKA person is going to be hyperventilating, okay? Because they're trying to get the CO2, which is acid, down to offset that. What do we treat clinically? We come in here and treat their metabolic problem. So we might be giving them like some insulin, or if it's like the sepsis, with our antibiotics, our fluids, our vasopressors, trying to get the tissue to perfuse. Now, the reason that pH gets that second name and the reason it works is because it's a rule of nature. The body will not compensate beyond 7.4. Once it hits 7.4, it can't go for, it stops. So in the preceding problem that we just did, number 5, the pH was 7.38. So what do I know from that? 5 minutes ago, 10 minutes ago, whatever, that pH could have only been something below 7.4. Okay, so yes, that patient was compensated at 7.38, but they would not have been up here and had an alkalotic value of like 7.44 and compensate down, 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 and then to 7, they would have had to stop at 7.4. So once you start on either side of this line, you stay on that side, or at least you have that effect. So that's why we can always give that pH that second name, because if we did not put a second name on here, and all you had was the name normal, you would not know which one to match it to. You would not know like where you're coming from, where your roots are, where your allegiance, your loyalty or whatever. You wouldn't know what why that pH was out of range to start with, okay? So that's why it gets 2 names when it's normal. So you can then use the matching rule and match up these 2 values or these 2 labels. Let's see it one more time here. So a pH of 7.37, okay? That is in normal range of 35 to 45, but again, it's below the 7.4, so it's leaning where it came from, or it's on the acid side of normal. So we can give it again the second name of within normal, but acid. CO2 of 58, normal 35 to 45, so this is too high, too much acid, so 58 is an acidotic value. Base excess of 14. So this is too high because the range is -2 to +2. This would be the same. It means the same thing that our bicarb is above the 26. And when I've got too much bicarb, a base, that's exerting an alkaline effect on the body. And oxygen 80 is okay again. So to name this one, even though the pH is normal, it's the acid side of normal. And which system is also acidotic? Well, my CO2 is acid, and CO2 means the lungs or the respiratory. So the underlying problem, even though I'm normal, the underlying problem is a respiratory acidosis, just matching these 2 up here, all right? And that was anything that makes you hypoventilate, the airway obstruction, pneumonia, pneumothorax, something like that. So there's an impairment to the breathing. Is it trying to correct itself? It's a respiratory problem. The metabolic side has to compensate, which means I look at the bicarb or the base excess deficit, and I say, is it normal or not? In this case, a base excess of 14 is abnormal. It's more than +2. So there is some compensation going on here. And then has it compensated? Go back to the pH. The pH is between 735 and 45. So we're in a compensated state here, fully compensated. And the full name for this would be a compensated respiratory acidosis. So this person, just to give it a clinical picture, this person has been having their maybe it's a respiratory arrest that we're coding or something or whatever. But you see the metabolic side is trying to compensate for that by jacking that up. What do I treat? I fix their primary problem. Their problem is a breathing problem, a respiratory problem. So I need to focus on that and change their breathing. The bicarb, the base excess, the metabolic side, it will come in line on its own. All right, so that was showing you just looking at the numbers and just naming the disorders. I'm going to go a step further and show people how this occurs more often as far as exam purposes. In any test, any exam, whether it be the CEN exam or something else clinically or some other continuing education thing, we have multiple choice answers. You know, you always hear the phrase, well, there's more than one right answer. Right, but there's always only one best answer. And so, and specifically for the CEN exam, this is actually how it's presented. They don't always give you just the numbers and say, what's the disorder? Sometimes they give you the numbers and they ask you to pick a nursing step, an intervention, or something that you have to know what the disorder is. So for example, this practice one we're doing here, and if you're watching along, I would suggest to take a screenshot of this or whatever you can do, because the answers will come up as I click through them here. So I'll leave it up for a minute here, and then you'll take a screenshot of the last one also. So this question gives us 3 numbers, and it says consider these numbers, and then it says which of the following is the best or most appropriate intervention. You're like, what? What is intervention? So how do you answer this? You have to identify the disorder, and then you can pick one of the answers. So we're going to do the exact same steps we just did on the 1 through 6, and we're going to do it how it shows up on the exam and get that experience. So I'm going to do the same thing. I'm going to look at my pH and say, is a pH of 7.3 an acid value or an alkaline value? In this case, 730 is acidotic. So I've given it a name. I look at my CO2, 25. Is that an acidotic number or an alkalotic number? CO2 is an acid. It's less than 35. When I lose some of my acid, it exerts more of an alkalotic effect. So CO2 gets the alkalosis name. Bicarb of 12, that's less than 22. Normally it should be 22 to 26. Bicarb is a base, so I have less base than I should, and that's exerting an acidotic effect on the value. So I've just named my 3 numbers here, okay? We're still not there yet. We need to go through the rest of the steps. So step 1, after I name these, is what is this disorder? And we did that by doing what? We matched the pH to the same system that had the same value. So the pH is acid, the bicarb is also acid. All right, so that means we have a metabolic acidosis going on. All right, so now armed with that, now that we can go further, we can say, is there some compensation happening? Remember, it's a metabolic problem, so go look at the CO2. Is the CO2 abnormal? Yes, there is some compensation here. Has it compensated? No, the pH is still outside of its range. So this actually is a partially compensated metabolic acidosis. So, as is true with most multiple choice professional certification board exams, you can usually throw out 1 or 2 answers right away. They're completely wrong. And in these examples, because we know this is a metabolic problem, I can throw out 2 of these answers because they're actually respiratory interventions. Okay, so answers A and D are wrong right away from an exam perspective, because those would be treatments if they're in a respiratory disorder. They are in a metabolic disorder. They could be like in DKA, sepsis, the salicylate overdose. I need to be looking for a metabolic intervention. So A and D are wrong. Another reason that answer A is wrong, because answer A would actually be for the patient who's in respiratory alkalosis, and we're in an acidotic state. So I've just proven beyond a shadow of a doubt why answer A is wrong. And for exam purposes, that's always great if you can take the time to look at each answer. And when you think you have the right one, make sure you can make a reason or a case why the other ones are actually wrong. Then you'll know you've got the right answer. Looking at answer B, clamp the NG tube. Okay, that's probably a metabolic intervention, but let's remember about the clinical scenarios. Who was the person having a metabolic problem that was having too much something taken out of their upper GI tract? That was the metabolic alkalosis, either from the profound vomiting or the too much NG tube suction. So I've just proven why answer B is wrong, because B would be for a metabolic alkalosis, and we're in a metabolic acidosis. Okay. How about C, giving insulin? Yeah, that's probably the right answer, because insulin would be given to the patient in DKA, and DKA is one of our metabolic acidosis conditions. So that's probably right, but we want to be really good and make sure I can find a reason why D is also wrong, and then I'm stuck with only one correct answer, which would be C. So I said D was wrong because it's a respiratory intervention. D is also wrong because it would actually be for a respiratory acidosis. Okay, and we're in a metabolic acidosis. So we've just identified, and this is the last screen, so if you want to screenshot this or clip it or paste it or whatever you do. So we've just proven beyond a shadow of doubt why A, B, and D are wrong. Okay, now, I had one class where someone said, how do I know this person is in DKA? Well, you don't, but that doesn't matter. None of the other interventions are a metabolic acidosis. Okay, so while you don't know they're in DKA, you have no other choice. Okay, they're not going to give you, if this was on like on the CEN exam or another board exam, they would not give, without giving you more information in the stem of the question, they could not give you multiple metabolic acidosis numbers. That would not be fair. You can't do that, because remember, there may be multiple good answers, but there can only be one correct answer or one best answer. All right. Now, the other handout you have is 20 practice questions to do on your own. The way you use that sheet, if you print it off or if I mailed it to you, depending on how you signed up, what you want to do is you want to get a blank piece of paper and only have the numbers showing. And then on your paper, just go ahead and write the names right next to it, and then slide it over one column and see if you got the right names, and then do your steps. Name the disorder by matching the pH to the abnormal value, or the one that has the same name. Think of some clinical causes, like, oh yeah, this could be the person who's vomiting so much for metabolic alkalosis. Look at the other number to see if it's starting to change, to see if you got some compensation happening. And then the last step, go back to the pH. Is the pH in normal range or not? And then you can slide it over and see if you matched the full name of the disorder. Number 13 and 17 on that practice sheet, those are examples of mixed blood gases. Now, mixed blood gases do happen in the real world, but for the purposes of learning and teaching and for exam taking, when there can only be one correct answer, by you seeing what 13 and 17 look like, because eventually your brains will say, what if it started compensating the other way? Well, one, it can't do that, okay? The other system does not compensate to make things worse. It only compensates to make things better. But sometimes patients present with multiple problems. So mixed blood gases do exist in the real world, but you will, if you're going on to take the CEN exam at some point or another test, you will not see a mixed blood gas question, because then there's multiple right answers. So for people taking the CEN exam, I tell them that makes actually blood gases a lot easier, because there's only one correct answer. So those are, by the time you practice through all 20 of those, you will have forgotten the first several. You could just flip the sheet over and do them all over again. And so it's a good way. And I encourage people to pull out the handout where it has the steps on it and practice doing those steps every time with the labels, the matching, think of a condition, look for the compensation. Those are the rules. And if you notice, we did all this without even talking about opposites or using arrows. All we did was remember that CO2 is an acid, and I asked, is the CO2 number too high or too low? Is it more acidotic or alkalotic? Bicarb, it's a base. Is it too high or too low? Is it exerting more of an alkaline effect or more of an acid effect? And that's all you got to do, and then match it to the pH there. So that's the end of it. I've got 2 different software platforms going. I'm gonna watch both chat screens to see if anybody has any questions or anything.